Welcome back. I'm Dr. Hanish Pansali, one of the PTAC members. Josh and the PCDT laid the foundation for this public meeting and some of the questions we want to explore. I'm excited now to welcome 4 esteemed experts to share their perspectives on multi-payer alignment across programs within Medicare. You can find their full biographies and slides posted on the ASPE PTAC website and the public meeting registration site. At this time, I ask our session participants to go ahead and turn on video if you haven't already done so. After all experts have presented, the committee will have plenty of time to ask questions and engage in what we hope to be a robust discussion. First, we are pleased to welcome Mr. Nicholas Minter, Deputy Director of the Seamless Care Models Group at the CMS Innovation Centers. Nicholas, welcome.
Thank you so much. And it's a pleasure to be here today. I'm going to give the CMS Innovation Center perspective on multi-payer alignment today and look forward to hearing the discussion to come. Next slide. So my name is Nicholas Minter. I have been with the CMS Innovation Center for 10 years. I currently lead the portfolio of models that includes what you see here. It's Medicare Advantage, kidney health, accountable care organization work on total cost of care, value-based payment and care, and then our prescription drug portfolio, which is also growing rapidly. Previously, I spent 6 years managing the CMS Innovation Center primary care portfolio. And before that, I spent 5 years at the Assistant Secretary for Financial Resources, or the HHS Budget Office, researching Medicare payment policy. Next slide, please. So first off, I thought we would talk a little bit about the definition. So multi-payer alignment, as we define it in the CMS Innovation Center, largely refers to the coordination and the collaboration among health insurance payers to meet common goals and patient outcomes, such as improving quality and reducing administrative burden. It largely is an acknowledgement that CMS can't influence or can't drive all change alone, especially those that are provider focused, where a provider is most effective at driving change at a practice level, and Medicare fee-for-service or even Medicare Advantage together are not going to be 60 to 75% of a provider's patient load. What is really necessary to compel a provider to change the way that they practice for all of their patients. And so this is something that we think quite a bit about when we are driving provider-based behavioral change through our models. And the incentive for us is that we are more able to see how better payments for care coordination, different types of interventions that we believe will make a difference, affect patients at a practice level, because we know that that is being delivered to all patients regardless of payer. And for other payers, the incentive it can be varied, but often it is better patient outcomes and therefore lower cost of care given the way that the U.S. health system works. The multi-payer alignment goals and tactics vary by model, but they often fall into 3 common categories. We often try to align on quality measures because we know that narrowing the focus of what a provider is being incentivized to maximize, to optimize, will help drive their focus on those more narrow set of goals. Payment alignment is really important to sort of strengthen the incentives on achieving goals. If we're all incentivizing care coordination, it's going to be a lot more effective than a smattering of incentives incentivizing all sorts of different care. And then aligning data, because data is really important for helping providers to understand what is driving patient outcomes. And in so much as that data is aligned across payers, they're more likely to use those tools and achieve the goals that those are meant to drive forward. And so, while the ultimate goal is to lower costs and to achieve better outcomes, multi-payer alignment does have intermediate goals that I wanted to acknowledge here as well. And those are to reduce administrative burden and in doing so, increase provider engagement. In essence, we want to provide go all in at the changes that we believe will make a difference in patient lives. But that's difficult with there being different incentives and signals coming across the entire payer landscape. And so one way to lessen that is to really align and to ensure that the provider is able to focus on patients and not managing different incentives across payers within their own practice and standard of care. Next slide. So where are we focused on multi-payer alignment, both present and past? First, I want to acknowledge that we have a couple of models currently that have factored multi-payer alignment into the successful testing and sort of our theory of action. The first is the ACO Primary Care Flex model, where we are aligning actively with the Medicare Shared Savings Program as well as other payers. And then the Enhancing Oncology model, where we're driving better coordination of care for those patients that are needing oncology treatment with private payers in a few of the areas and where we're testing. We are also integrating much more significantly, I think, than in some models, multi-payer alignment in the following models. The AHEAD model, where we're focusing on global budgets across Medicare and Medicaid to drive better preventive care. The ACCESS model, where we are making technology available across payers to better address chronic care issues. And the LEAD model, which is our forthcoming ACO model, which is also looking to, among other alignment issues, work very closely in a couple of states for now with to align Medicare and Medicaid care. All of these new models, as well as our current models, apply lessons learned from past models that tested multi-payer alignment, particularly in the advanced primary care space. And you see those past models here: Comprehensive Primary Care Plus, Primary Care First, and Making Care Primary. And we're going to talk about what we learned from a couple of those models in the forthcoming slides. Next slide, please. So first, a little bit about the models that I want to reflect on today. First, Comprehensive Primary Care Plus. It was tested from 2017 and ended at the end of 2021. It was a 5-year model for 2 cohorts. It essentially paid an additional payment on top of the normal fee-for-service set of payments for care coordination in primary care clinics and family medicine, et cetera. It also had a small performance-based payment / debit approach. It enrolled over 3,000 practices at one point across 18 different states and regions. And at model start, had 63 payers across those 18 regions that signed up to provide similar additional support in terms of learning, payment, and data to those practices that agreed to participate in CPC Plus. The other model that we'll talk about is the successor model of CPC Plus, and that is the Primary Care First model, which began in 2021 and then carried through until the end of last year, 2025. It was a 5-year model as well, and it had essentially a partial upfront payment as well as a capitated payment for primary care, but also incorporated upside and downside risk. It had 1,700 practices across 26 states and regions, and 17 payers aligned model start, and we'll talk about sort of how that changed over time. Next slide. So wanted to note, again, not specific to each model, but some of the takeaways, both positive and negative, from our experience implementing multi-payer alignment in these models. The first is that just the focus on multi-payer alignment often fosters incredibly important discussion that otherwise may not happen. Often starting a conversation is the hardest part, and payers, due to different regulations regarding antitrust and concerns about talking to competitors in the market, are often not willing to think through or feel somewhat stymied in their ability to think through how to improve care in a way that will affect providers, because they, of course, are dealing with multiple payers at a time. And having CMS at the table had a real tangible impact in that focus. Additionally, what we found is that, especially in CPC Plus, some of the collaboration that began during the model and would have ended in 2021 has continued and still continues to this day. And so that's something that I think has been really interesting for us in terms of just CMS's presence to move a conversation forward. Also, multi-payer alignment does enhance support for behavioral change. One of the things that it's very true is that providers are more willing to participate and more excited about change when they know that it has the potential to reduce friction across the different provider or the different payers that are dictating how they provide care. So as I said before, Medicare fee-for-service amounts to what we found in our practices between 20 to 40% of providers' revenue. And so that leaves 66% of revenue that can be pulling providers in a different direction. And if we can have everyone pull in the same direction, then we move a lot quicker. And so aligning data, learning, and other resources was something that providers universally really appreciated in our models. That being said, it's hard to drive behavioral change without enough payers sort of pulling in the same direction. And so as a result, what we did find, especially in primary care first, but also in CBC Plus, is that in some regions, providers felt that even with a number of payers supporting, there still just wasn't enough momentum for them to change the way that they provided care at a practice level. And it was too disruptive for them to differentiate how they provided care at a patient level. And so, especially in PCF, where we had less multi-payer alignment over time, we actually saw that many practices started to drop out or jump to test other innovations because they didn't really feel like there was enough oomph for them to make the change that would really improve patient behavior, given that there is friction in making change to begin with. Let's keep going. Next slide, please. Which gets to, I think one of the more important takeaways that we've learned on multi-payer alignment, which is that it helps to think and define both for payers and providers that may be participating in models, what multi-payer alignment is going to be defined as for a given model. Do we want them to be equal partners, such that if we're putting in $1 per patient, they're putting in $1 per patient? Or is that equity less important than us all just sort of moving in the same direction? What we found is we defined it more along the first lines with an idea that we wanted to get payers to be providing more equitable support over time. We never quite got there. And so what we found, and as you see in the graph to the right here, is that CMS ended up paying an inequitable or disproportionate amount of the payments above fee-for-service and above what would otherwise be available for each model. And so along those lines, we also found that some of the payments that were coming in from other payers were aligned to programs that they already had running. And that's not necessarily a bad or a good thing. Important that we're all sort of speaking with the same voice and how we want providers to change. However, what we found is our provider participants were often confused and somewhat dismayed that they were not receiving more additional payments from all of their payers. And that put them in a position of either only treating CMS patients with the additional care coordination and additional services that they believed would affect their entire practice, or in effect, CMS's additional support was cross-subsidizing care transformation at a lower level because the funding wasn't there to test it at the level we wanted to, but cross-subsidizing that change for patients that were covered by other payers other than Medicare fee-for-service. And so that brings us to the last sort of challenge that I think that we have acknowledged and are grappling with in our models going forward, which is that the limited scope of CMMI tests creates administrative fragmentation, especially in our larger Medicare Advantage organizations and just general national payers at large. So in PCF, we had 6 payers that left in the beginning, I should say throughout the model, not at the beginning, because they realized that they needed a dedicated staff, the capitated payment changes required additional infrastructure, and the return on investment would have been too slow for them to actually sort of see that being a positive for them long term. And I think that is something that we have heard across all of our primary care models, that especially for national programs, they are thinking about driving change at scale and asking them to invest in smaller changes, especially those that require significant investment up front and have a slow return on investment, is a big ask. And so that's our takeaway, that multi-payer alignment is hard when the population is broad, the services are numerous, and the return on investment is slow and uncertain. And so going forward, we're thinking about how to focus our change in a different way. And we'll talk about that quickly on the next slide. So with those lessons in hand, I just wanted to highlight what the future areas of interest for multi-payer alignment is. For us, these are areas that we're thinking about. We are, in different stages of planning all the time for how to address new healthcare problems because they are numerous and complicated. And so one of the areas that we are thinking about is Medicare Advantage, especially as Medicare Advantage has eclipsed fee-for-service over time in terms of the number of Medicare beneficiaries covered. We want to think about how to increase value-based care. We also want to reduce, frankly speaking, and specifically the administrative burden of providers that are participating in multiple models that include Medicare Advantage, because we know that, there will always be, unless we address some of these lacks of alignment, there will be friction between things like real-time patient outcomes that come from an EHR and stars ratings and those measures, because they look at something different. And the incentives are already strong in Medicare Advantage. And so we've got to think about how to align this going forward for providers to be able to lean in models that address Medicare Advantage outcomes. And the other area thinking about quite a bit is condition-specific populations. As I said, primary care models were characterized by prevention, which has a slow return on investment across a broad population. But there are providers and populations that are at much higher risk for future acute care issues that we can focus on and believe that we can make a difference in terms of return on investment on a much shorter time frame. You can think of the chronic kidney disease population as one such area where averting future crashes into ESRD and hospital visits as someone reaches that stage of remedial care can save a lot of money, both for Medicare term, but also for payers who have to then fund a very expensive transition period. And so as we think through those potential possibilities, we believe there is a lot of hope and potential for multi-payer alignment in the future. Thank you, and I look forward to the discussion.
Thank you, Nicholas. We're saving all questions from the committee until the end of all presentations. Next, we are glad to welcome Ms. Dana Rai, who is the President of Value-Based Care at Dooley Health and Care. Dana, please go ahead.
Thanks, Dr. Rensali, and thank you all for the opportunity to participate in this important conversation. I have the opportunity of representing Dooley Health and Care. You can go to the next slide, please, the largest independent multi-specialty provider in the country. I am the president of Value-Based Care. This is an important and high-performing part of our business, encompassing over 400,000 patients across payers and risk arrangements. Next slide. A bit more about Dooley. You can think of us as a large single practice, but we're so much more than that. We're really a full integrated delivery system. We have 1,800 clinicians, 190 different locations, a full suite of ancillary services from lab, diagnostic imaging, ASCs, urgent care, and infusion centers. We serve 1.2 million patients, and as I mentioned, nearly 400,000 of those are in some form of value-based care or risk arrangement. We have incredibly high provider retention, best-in-class patient experience scores, and of course, are most proud of our clinical quality. Next slide. Now, this footprint makes us uniquely suited to excel in both fee-for-service and value-based care. With our primary care at the center, we leverage the strength of this model to provide timely, cost-effective, high-quality care. Because of our multidisciplinary footprint, we're able to keep the majority of our office-based professional services in-house, which enables countless life-changing stories of same-day appointments and referrals. For example, just a few weeks ago, PCP uncovered a possible macular hole. She walked the patient down the hall for a same-day evaluation by a retinal surgeon. who confirmed the diagnosis and scheduled an immediate procedure, likely saving that patient's vision. Just one example of many that happen every single day because of the ability to deliver care across specialties and ancillaries. Next slide, please. So a large part of this success is because of who we are. We have tenured patients who on average have been seeing our highly aligned, mostly shareholder physicians for over 10 years. That allows the physician to deploy care across specialties and our ancillaries, all while integrating our value-based care data and care management seamlessly into the provider workflows. Next slide. On top of this core foundation, we deploy programs that wrap around that physician-patient relationship and ensure the patient receives needed support between physician appointments. Some examples of that are noted here. For example, our care management teams are in the clinic, so physically located with the team, serving as a true part of that physician's care team versus an external unknown person, which is how many care management teams will operate. Duly at Home, a program that enables that patient's provider to treat them even if the patient can't come into the office, facilitating a telehealth with the provider who knows the patient, knows their story, knows their background, while a certified paramedic can actually put hands and eyes on the patient, checking vitals, administering IV fluids, and more. We have programs that manage hospitalizations, readmissions, and support patients through post-acute and specialty journeys, all of which is coordinated through our primary cares. Next slide. And our numbers affirm that this foundation plus our programs drives positive results, whether it's the important operational metrics like having 90% hospital follow-up visits or proper documentation of acuity, achieved by seeing these patients regularly at the right site of service at the right time by the right provider. For example, over half of our orthopedic procedures now take place in an ASC versus a higher cost hospital setting. And we're really proud of driving that improvement, which is a better patient experience and drives significant cost savings to the system. I'm most proud, however, that we've reduced hospitalizations by 43% for our most medically complex patients in our Care Ally program. This is our version of care management. It is nurses working with the riskiest and most complex patients that we have as an extension of the primary care and ensuring that those patients receive everything they need to positively impact their health outcomes. We've also reduced readmissions by half for patients that we see at homes through that Duly at Home program, or a 30% reduction in our oncology patients needing to visit the ER because of those care management programs. We're incredibly proud of this patient impact, and this is translated into significantly impressive and strong value-based care program results across payer types. Next slide, please. So as I mentioned, we're active and top performing participants in a range of both Medicare Advantage and Original Medicare programs, previously ACO REACH and now MSSP. We have roughly equal patients in both programs, so this allows us to compare results across meaningful populations. Each of them has tens of thousands of patients in them. And importantly, we deploy our internal programs consistently across the two. We will, of course, distinguish between patients, for example, the highest risk patients needing a different level of care than a patient of average risk, but we don't look at their insurance when figuring out how to deploy those programs. And so it is interesting then that we see much better outcomes in our Medicare Advantage risk population than we do in traditional Medicare. For example, as you see here, hospitalizations are 35% higher and readmissions 14% higher for the original Medicare population, even though the number of chronic conditions per patient is not materially different. So given that these programs are deployed consistently and the population does not appear different in terms of their level of acuity, we see three main reasons for this diversion. First, attribution and the strength of the PCP relationship. When a patient is closely tied to a dually PCP, outcomes are better. More Medicare Advantage patients have a dually PCP, and they engage with their PCP more frequently than ACO REACH patients do. Number two, data accessibility. Medicare Advantage provides significantly more and more timely data than we receive through ACO REACH or MSSP. And finally, supplemental programs. These are offered by Medicare Advantage plans who are also highly incentivized to improve outcomes and lower cost. They use tools like utilization management and prior authorization, which, while not perfect, are an example of why we saw 1% of the skin substitute spend in Medicare Advantage than we did in the ACO REACH population, again, despite roughly equal population sizes. They include a host of other patient services as well, again, sometimes additive to the ones that we provide internally. Next slide, please. Here we'll go a little bit deeper on that first point of attribution and PCP alignment. And you can see here that the data clearly shows when there's an aligned dually PCP, clinical outcomes are better. And some examples that are listed here, right? 150% more admissions in original Medicare when there's not a dually PCP, roughly 65% greater readmissions, roughly 70% greater emergency room rates. And as this shows, this is true across payers, but it is more pronounced in original Medicare as fewer patients have that aligned relationship due to the stricter, more formulaic attribution compared to Medicare Advantage. While we make every effort to engage patients and offer them dually's excellent care, Medicare Advantage plans and their attribution offer exit ramps for patients who are truly not seeing dually or do not want to engage with the system, as well as multiple paths to add to those patients so that we can provide all of these services for them when we're actively providing care for those patients. Our Medicare Advantage patients also see their primary cares more frequently, which enables the PCP to more effectively quarterback that care. Next slide. Expanding on the other differences that we see, Medicare Advantage provides more and more timely data on the left side of the slide. This allows us to act instantly. For example, our ability to coordinate discharge planning while a patient is still in the hospital for that hospital follow-up versus learning about the hospitalization through claims data much later. Third-party companies do sell this information, and we purchase it for original Medicare, but it's expensive, and more problematically, it is not comprehensive, as it requires each hospital to agree to share that data with the third party. So as an example, to put this into context, while we have 35% more admissions in ACO REACH than we do in Medicare Advantage, as we showed on the prior slide, so you would expect 35% more notifications, we see far fewer notifications come through for ACO REACH than we do for Medicare Advantage, meaning it is more difficult for us to act on that in a timely manner. Lastly, on the right side, Medicare Advantage plans offer supplemental programs that at times are additive to our consistent internal approach. Examples of this can include expanded care management and wellness programs. Others that I mentioned earlier, like which when deployed appropriately, can be another lever to both help the patient and avoid wasteful low value spend, such as the skin substitute example that I mentioned earlier. So to close, we appreciate PTAC's interest in this important topic, and thank you very much for including dually's perspective. We're glad to address any questions during the Q&A portion.
Dana. Next, we are happy to welcome Dr. Karthik Rao, who is the Chief Medical Officer at Agilon Health. Welcome, Karthik.
Thanks, Dr. Bensali. Appreciate it. Pleasure to be here and nice to meet everyone. I'm Karthik Rao, primary care physician at Leahy Clinic in Boston and Chief Medical Officer at Agilon Health. If we flip to the next slide, I'll actually start with our mission. So our mission is to be the trusted long-term partner of community-based physicians, ultimately enabling them to reimagine the care experience for seniors and lead the transformation of care delivery in their communities. And so when we think about our care model and how we do that, there's really three pillars that we focus on. One is partnership, two, our platform, and three, our network. And so from a partnership perspective, every partner or community-based group that we work with is truly a partnership, which means we form long-term JVs for full risk, multi-payer Medicare lines of business. And what that does is it ultimately aligns economics with outcomes that we are trying to create with that group for those patients. Two, our platform. I really think about it as a purpose-built platform specific for Medicare across all lines of business. And I think that the key to note here is what we're really doing in that platform is we're taking disparate pieces of data, claims, EMR, ADT, creating a patient level profile of them, and driving point of care insights across our care model to ultimately create better quality care. And I'll talk in more depth on how we do that. Lastly, I think is also really important, which is our network. We are a network of 3,000 physicians taking care of 500,000 lives who are all full risk. And our physicians are entrepreneurial, they're innovative, and we share best practices that they come up with and drive those across the network, which allows us to innovate quickly and efficiently. And so with that, let's move to the next slide here. And so where are we? So we're in 28 markets across 12 states. And a few things to know, I mentioned we are roughly 500,000 lives. 400,000 of those are Medicare Advantage full risk. About 100,000 are in ACO REACH. We have several different archetypes of community-based groups that we work with. Community-based health systems, multi-specialty groups, large IPAs, and also single TINs. Which both creates unique opportunities for us in the value space and also unique challenges that we have to work through. We can flip forward one more here. And so, I mentioned in our care model, we're trying to create a single Medicare experience for physicians and patients. And on the left, you'll see the challenges our community-based groups were dealing with prior and how we've helped solve some of those problems on the right. And so to walk through this in some detail, the first I'll mention is disparate contracts with different plans and Medicare Advantage that require different parameters for success, whether that was quality metrics, thresholds for quality metrics, or how those incentives were ultimately passed back to the group, create a lot of challenges for them in actually operating to those contracts. Two is point of care insights and data. Ultimately, to perform in these contracts and change the way care is delivered, you really have to deliver point of care insights that support providers making the best decision for that patient in that moment in time. That's very challenging to do when your data constrained, your exchanges are challenged, and you have different metrics you're operating against. And lastly, I think the reporting against performance has also been a challenge previously. You can imagine the complexity of getting to streamline reporting when there's so many metrics and contracts in place. So on the right, what we've really tried to do through our partnerships with our groups is create a single line of business for senior lives. And so we look at a senior life as a senior life. We don't differentiate between plans or CMS full risk programs. We really just focus on doing the right thing for that patient in front of us. And so that creates a single MA line of business experience. And two, we spend a lot of effort actually making sure every patient has a complete data set that integrates claims, EMR data, and ADT data. And we construct our care model to perform against a set of metrics and outcomes where we're trying to optimize both quality of care and reduce unnecessary care that does not add to the experience or benefit of that patient. And we deliver those insights to nudge PCP behavior at the point of care. We think that's critical to actually changing care for those patients. And so I'll talk a little bit about our care model on the next slide. And so, just to summarize, single line of Medicare business that we've transitioned our groups to, ultimately trying to standardize quality metrics that they perform against and delivering those insights at the point of care. So what are those insights really trying to achieve? And so if we look at this slide, our care model is really built on a patient-centric lens of understanding where we have the biggest opportunities to improve quality of care, but also reduce spend that does not contribute to better outcomes. And the way we think about this is really in three ways. One, really understanding who our patients are. And so we use algorithms to risk stratify patients based on a number of factors. Two, really matching and really being purposeful about the interventions that we are creating for those patients. We can't do everything, so we really have to focus on a narrow set of activities that we think will meaningfully move the needle. And I think that's important to be focused because we make significant investments on core capabilities that you see across the bottom of this slide on really getting good at those things and continually optimizing. And I'll share a few examples of what that looks like. So for our most complex patients, which you see in the second column, these are patients with advanced illness, end-stage heart failure, end-stage renal care, end-stage COPD. We offer 24/7 access in the home for these patients because there are critical points in their care journey. And we think we can really meaningfully make a difference in their lives by offering them that added level of service. And that also holds true for many of our high-risk patients, which are in a slightly separate tier. But again, multi-comorbid patients, often in and out of the hospital, they're dealing with coordinating care across a number of different specialties and entities. We have in-home care capabilities to support them as well. Clinical pathways. We really believe for the majority of seniors, there are about 5 conditions that we want to be best in class at managing proactively and end-to-end. And you see those here: CHF, COPD, dementia, CKD, and diabetes. These are conditions that are highly prevalent in the senior population. They are conditions where we see significant care gaps in care patterns that exist today. And it's for good reason. PCPs are busy. They often don't have the time that's complex to actually treat a lot of these conditions and really close all those care gaps. And so what we found as a common theme through a lot of these conditions is a need for pharmacy care. And so we have pharmacists across all of these conditions that help close care gaps, will help patients with any cost concerns and find alternatives. And we've seen just an example in CHF, moving our guideline-directed therapy rates from baselines of around 20% to 70% on 3 and 4 drug regimens. And as a result, we've seen readmissions and admissions for that cohort come down significantly. Like most groups in value-based care, we also focus on burden of illness and quality, episodes of care, and high-spend specialties. I think and we continue to progress and optimize in those areas as well. So next slide, please. And so we talked about a few things coming together. We talked about our platform, we talked about what our care model looks like, and we talked about our network that helps us innovate. And so where has that gotten us in terms of results that we've been able to achieve? From a quality perspective, we consistently perform above 4 stars. We've done that, going back to 2020, and our results continue to be promising in that area. From patient access perspective, we think access is critically important, and we think that's a part of right care, right time, the right place. This is just one measure of that: annual wellness visit completion rates. We're well north of we're at 76% north of the fee-for-service average. But you also see access metrics such as touch points and PCP to specialist visit ratios be meaningfully better for our network relative to comparison groups. And lastly, from an outcomes perspective, are we reducing unnecessary utilization? And so on readmissions, hospital admissions, and ED visits, you see our outcomes to the right. And what you see across those 3 metrics is our readmissions being about 20% lower than a fee-for-service benchmark, our hospital admissions being about 15% lower, and our ED visits being about 35% lower. And so I think through our care model, our proactive care, our focus on specific disease segments, we've really been able to move the needle on how we perform, both from a quality of care perspective and experience for seniors. Next slide, please. And so what have we learned through this process? And so, I'll start with the top line. And I think that is full risk in MA can really mean different things by plan. And what it can sometimes feel like, we operate across 30 different payers, that you're really in 30 different programs. And that plus ACO REACH and MSSP that we operate in creates a lot of complexity. And I'll hit on 3 areas where I think that really comes to light. One is attribution. And so we are obviously at full risk for all the lives that we take care of. We see real differences in when we get attribution data by plan. So our best payer partners give us attribution data in January, which allow us to be proactive and engaging with those patients and really helping them benefit from our full care model. Other plans don't provide us attribution data until April or May, which really puts us several steps behind, both in engaging those patients and put our contracts at risk from being delayed in what we can do. Those tend to be smaller regional payers that are less sophisticated. Two is data asymmetry. We generally have a pretty good experience in ACO REACH, both from the timeliness of data and also from the completeness of that data that we receive. In working with MA plans, we see a lot of variability and timing of data. Incomplete data sets, both can be on the claim side and also on the risk adjustment side, and also different data structures. And, again, mentioned we work across about 30 different plans. We spend, upwards of $500,000 for each of those plans to restructure data, making it usable, allowing us to be able to do things like point of care insights that allow us to change care patterns for the patients in our care model. And last, measuring success, which others have hit on as well. And so there's variation in MA plans and even by MA plan, ACO REACH, and MSSP. And the difference in quality metrics, the thresholds for those quality metrics, and how incentives are paid out create a lot of complexity in how we manage both from a contracting perspective and delivery of care, and also in contract performance. And so, moving forward, I think we have a real opportunity to be more clear on what it means to be in full risk by stakeholder, whether that's data requirements, attribution, or quality metrics. I think creating consistency across those things will reduce the administrative burden in succeeding thing programs and ultimately allow us to focus more on care delivery and the physician education that's required to succeed. And so I'll pause there.
Thank you, Karthik. Finally, we're excited to welcome back Dr. Michael Chernew, Professor of Healthcare Policy and Director of the Healthcare Markets and Regulation Lab at Harvard Medical School. Please go ahead, Mike.
Yeah, thank you so much for having me. It's wonderful to go last. Listening to Nick and Dana and Karthik is really educational for me. I think the reason I do this is so I can just hear what the other speakers say and get the questions. And I have to say it warms my heart to see all of this type of activity going. And I actually do think there's a lot of merit in what some of these organizations like Dooley and Agilon are doing. And so we actually see some care transformation happening. And I think the evidence might not be as overwhelming as people would have liked, but I think there's clear evidence that well-designed programs can improve quality and reduce spending. And so I'm excited about all of that. So now, since unlike the other speakers, I don't actually do anything, I will have a shorter set of comments and then we can go to the committee's questions. But can you advance the slide? So the first thing I need to say is the opinions, everything I'm going to say now, they're just my personal views. They don't necessarily reflect the views of any organization I'm affiliated with. Most importantly, they don't reflect the views of MedPAC. All right, next slide. So I think a key thing here that everyone has emphasized, so I won't emphasize it, I just have more pictures than words, is it's just really hard to succeed when physicians are facing multiple incentives. So they're getting different incentives from the MA plans, they're getting different incentives potentially from ACOs, there's obviously fee for service, and this is largely just in Medicare. Now, the way that I put this out, I have the ACO incentives coming at the physician separately from the MA plans. But I think one of the things you've seen from both Dana and Karthik is the ACOs can actually be between the MA plans and help harmonize what goes on. I think that's a very important role for conveners. But the key point here isn't how the arrows go. The key point here is it's very hard to practice medicine if a lot of different groups are telling you how to practice medicine. So let's go to the next slide. So this is my main point. This will come up again at the end. And by the way, I'm almost at the end. Alignment's important, and easier to align the programs if there are fewer programs. One of the problems that I've seen and that I worry about is there's just a lot of programs and they're just changing a lot. And so I'll say a little bit more about alignment in a minute, but it's just very hard if you're trying to align population-based health payments, episode payments, and the MA plans are doing their own thing, which CMS doesn't have a direct insight into. And then you have a series of other programs that aren't necessarily exactly episode or um, ACO type programs. And so my sort of first broad comment, and I would say the main theme of this is it is hard to align. Nick pointed that out very clearly for a bunch of reasons, but it's really hard to align if you have so many things going on and you're trying to align micro parts of all of those things. And I think one thing that came from Dana and Karthik's point is there's maybe some big picture areas where alignment might help um, for at least some of the population-based health things. So let's go to the next slide. So what dimensions of alignment are there? So one is quality measures, and I think that's important. I think there's a lot of stuff going on for quality measures. The more they can be aligned, that's important. So it came up, data requirements matter, and I think CMS, and the more they can modernize their data requirements and modernize the data and the data flows, things will be better. Risk adjustment matters. So I think there's big differences. Risk adjustment itself, I think, needs a real serious overhaul, but I think aligning it across similar programs ends up being quite important. The one that I think Dana and Karthik mentioned a lot was attribution, and I think that certainly matters a ton. It's hard to succeed in these models if you don't know who's in the model. And then the last one is financial incentives, and I'm going to say a bit more about financial incentives because it happens to be an area of interest of mine. But you do want the financial incentives to work in a way that helps providers succeed if financially if they do the right thing. And that ends up often being a tension between fee-for-service type programs and ACO type programs. But I would be remiss if I didn't note that one thing that's happening in fee-for-service is the addition of a whole bunch of codes that are kind of not like population health code. They're sort of like population health codes, but they're not really ACO total codes, a bunch of G codes and things like that. And it's very hard to align the incentives if you're trying to do everything in every program. So next slide. So some challenges to alignment. The programs often have different scopes. So we've talked a lot about total cost of care programs, which is often these groups that take full risk, ACO, and even contracts, MA plans where you take full risk. But there's also a bunch of episode-based models. And I think aligning between the episodes and the population-based models will end up being particularly important. There are inherent attribution differences between ACOs and MA. So a lot of people talked about attribution, so I'm not going to dwell on it now. But again, I do agree that attribution and getting it right matters. And I should say the nuance there is that we attribute people to MA plans well. The actual attribution of MA plans to practices is something that's sort of outside of CMS's direct purview. And as was noted, plans, some do that better than others. But the ACO type attribution is something that CMS does, and figuring out how to align that with other attribution models and across attribution models would be important. One big problem ends up being the multi-nature layer of care. So there's population-based programs and fee-for-service, a bunch of others. There's not enough room to draw all of them that affect the provider group or the health system. So there's money going there. But then the doctors themselves or other professionals, they're getting incentives maybe from their health system that may not exactly match the type of incentives that are coming from the payment model to the provider group or the health system. And so aligning that. So for example, this fits into the statement that people say, look, you're giving us total cost of care to the delivery system, but the doctors are still rewarded on some fee for service basis. So there's some amount of aligning that I personally believe it's the responsibility of the provider group or the health system to harmonize their different incentives so that the doctors and the other professionals and all the other things that are going on are kind of moving in the same direction. One of the big problems ends up being legacy systems. You want to align things across payers, but not every group can manage in their IT systems doing a bunch of things. So it ends up being quite hard. If you want to align quality, for example, or if you want to align risk, you really need to think through how the IT systems in these different groups are working. And those legacy systems can sometimes be a real barrier to what's feasible on the ground. And then the other problem, which I think is particularly true when you think amongst, let's say, the MA plans, is uh, alignment often requires some version of standardization. Maybe we can have a semantic discussion about the distinction between alignment and standardization, but typically it involves some aspects of standardization. And there's often organizations that believe they have some type of secret sauce and they don't want to align. They want to see what other people are doing and then add their secret sauce sort of on top or below or besides what that is, which is fine, but it makes it complicated to do alignment. The problem is if you do that standardization, you worry about innovation. You don't want organizations say you could do better attribution or better quality measures or whatever it is, not to be able to do that because now you've aligned everybody doing the same thing. So I think that my personal view is we need a little bit more standardization in the scheme of things. I think the administrative burden and the lack of alignment is actually a worse problem. Um, but I think that issue remains up for debate, and the devil will be in the details when there's a particular proposal on the table. Next slide. So this is really my last original slide. But I want to raise one other point about alignment that hasn't really been raised, which is this point that I've made in another piece, which is waste is an asset. So the goal here is that we want to incent the delivery system to provide higher quality, lower cost care and share the savings with them, hence the things like shared savings program. Different alternative payment models assign the gains from efficiencies to different stakeholders. So there's the total cost of care models, but there's also episode models and there's different things that might go on in the fee-for-service system when you add certain types of chronic care management codes, or certain activities like avoiding a post-acute stay or shifting someone to a lower cost imaging procedure or doing a whole bunch of things. That savings is going to have to get split between organizations. And you may have different organizations that have some claim on that savings, say an episode provider or an NACO. And so it's important to think through how waste is assigned because it affects the incentives to save and participate. So in a world where we have a whole bunch of different models that are floating around, thinking through the participation rules and who gets to keep the savings and how to do that in an aligned way matters. Um, the general gestalt of the MedPAC recommendation, which I believe in, is the APM should be synergistic and default to population-based, say, total cost of care models, and then they should add synergistic episodes or other models on top of that base foundation. But I think too often one problem we have with alignment is people begin to ask, how can we build a model to accomplish this particular small goal? Chronic care management, well, that's a big goal. But managing a particular patient type in a particular way. And the issue is, even if you do that correctly, understand that in these population-based models, that population, the organization that holds population accountability has an incentive to do that. And so trying to figure out how to align the incentives across different types of programs and how to manage who's able to participate in them matters. And I think it becomes complicated when you try and build a bunch of population-like features in fee-for-service, which is inherently not well-oriented to population-based management, to then align that with what's going on in other, say, more direct population-based management type programs. And if you don't do that well, or if you're not cognizant of it, you'll mess up the participation decisions and the entire thing will just become administratively burdensome and too complex to operate. So let's go to my last slide, which was really one of my first slides. Um, so I'm just going to close with this, and I look forward to questions, and I hope I get to engage with Nick, Dana, and Karthik on these points. But again, I think a core point is it's much easier to align the programs if there are just fewer of them. Having a general vision and building that vision out in an aligned way is, I think, important. And I think that's hard to do if we come to the discussion with the notion, all right, we've launched a bunch of programs in 2026. When are we going to launch in 2027? Or if we come to it from the point of view of, well, I'm in charge of the Part D program or the Part B program, or pick your letter, and we also need to do something related to chronic care management, drug pricing, site of care, whatever issue you want. And so we're going to launch a new model to try and get at that. Because every time you try and launch a new model to try and get at whatever the particular thing you're worried about, you have to think about how it interacts with all the other broad models, particularly the population-based models, which ideally would be able to have a much more holistic view of pulling these things together. So the next slide, which is just going to say end. I've enjoyed at least my brief time to be able to talk with you all, and I really look forward to the discussion. So thank you very much.
Thank you so much, Mike. And thank you to all our experts for these great presentations. Now let's move to the discussion portion of the session. At this time, PTAC members, please raise your hand in Zoom if you have questions for our guests. Additionally, we want to encourage our experts to ask follow-up questions of each other. You can signal that you have a question by raising your hand in Zoom. In the interest of ensuring balance across different perspectives and questions, we encourage experts to keep each response to a few minutes. All right. Now I am going to take a look to see who has their hand up. And if no one, then I see Lauren with her hand up first. Lauren, please go ahead.
Thank you, Hanish. Excellent presentations. Dana, I have a couple questions for you, and I welcome the other panelists to comment as well. I was really intrigued by the care management infrastructure that you have, and to see the diversity of roles, from paramedicine to nurse case managers managing the highest complex, and it looked like as well community health workers potentially in the care ally role. So I'm curious how you coordinate that infrastructure, if it is coordinated and connected at a central level, and what insights you've gained from working with different disciplines and that coordination to achieve the outcomes, reductions in cost and improvement in quality that you've seen.
Sure, and thank you so much for the question. And it is with living in the day-to-day of it, to take a step back and look at that comprehensive suite and the way that we lay it out in that slide is very special for me, and something I'm very, very proud of that we've built. And yes, it is a whole host of individuals, including many of the ones that you mentioned, and a lot of ones that don't jump through. Like there's MD specialists, for example, involved in that as well. There are front desk employees at our clinics. There's call center staff that serve all of our 1.2 million patients. And so yes, is the short answer. It requires a tremendous amount of coordination. I'm sure we've all seen examples of when additive services are done in a way that is not well integrated. It makes for at best a clunky experience, and then when it plays out worst, patients getting conflicting instructions from different places, which leads to again at best neutral outcomes, if not poor outcomes. And so we have, because of the scale of our programs and our commitment to value-based care, invested in those back engines, I'll say, and that's everything from the data, the processes, and probably the part I'm most proud of, the team, to help make sure a team of excellent operators who've been in the space for a long time. And I really do think that is what's necessary to make those pieces all come together. One of the many reasons why it's so hard for smaller organizations that don't have the confidence, the track record, the dollars to invest in aggregating programs to those levels. And one of the reasons why I am glad that there are organizations like Agilon out there for groups that wouldn't be able to do this on their own. So happy to go into more detail on any of those pieces if helpful, but we'll leave it there for now.
Dana. Lee?
Yeah, wonderful presentation. I appreciate that from everybody. I was really struck that I think I've heard, involved in PTAC now going on 7 years, I guess. I think I've heard something across all four of you that's the first time I've ever heard it said this way in a PTAC meeting or discussion, which is, Dana and Karthik, your team's out there doing the good work every single day. You all both in your own way said really clearly that MA is the winning model, and you try to bring Part B wrapped in an ACL alongside that. But MA is superior for attribution, relationship, better data sharing. I love at Agilon, you talked about essentially blending all that together and providing both financial and program arbitrage for your providers, so they only see one program, but MA is a big part of that. Mike, you said it's hard to align. There's lots of programs, and so fewer programs may be better. And that's the theme we've picked up before, saying maybe it's time to stop making up new models and time to start enforcing what we know works, however we do that, right? And then Nicholas, you talked about, CMI is increasingly aware that it's hard to get to 65 or 70% of the patients involved to move systems and providers if MA isn't involved, and CMI sounds like it's looking at how MA can be involved. And so that's really a first. And so I guess I'd love to throw it open to all of you to talk about that specifically. Are we kind of entering a new era where multi-payer alignment from CMS's perspective is going to include weaving MA into programs and trying to streamline metrics, policies, philosophy, as much as we have been focusing for the last 15 years in PTAC, pretty much around just Part B alone? So love to hear your reflections on that. Whoever wants to go first.
Yeah, maybe I can start, and then others can layer in. And Terry, you mentioned one of the things that came out was maybe MA is the clear winner, and I might take a step back from that and say, I actually think we do pretty well on the ACO REACH side too, and we've had a good experience there. When I think about the 30 MA plans that we work across, it's really tough to say they're all the same. There's a lot of heterogeneity within that, and I would say some are clearly at the top quartile of who we work with. And in that top quartile, what we generally see is pretty standard data requirements like timely attribution, and I would say benefits that align with our view on what good care means for a patient, which I think really allows us to get on the same page pretty quickly with them to focus on patient care without all the administrative burden of what we're trying to do in the background. And so I do think there, to your point on how we can work through requirements, like it's clearly going well in some places on the MA side. What can we learn from what they're doing, and even components of ACO REACH to say, how do we create standard components of that everyone can get behind? I think Michael mentioned one of the biggest challenges, which is a lot of small regional MA plans have very dated stacks of technology and other things they're using. And if you were to ask them to do that today, they just can't. And so there's probably a will, but not a way in some of those areas. And I think that's part of the challenge to work through.
Mm-hmm. Mm-hmm.
I guess the one thing I would add, I mean, I appreciate the summary and would agree that, multi-payer alignment, I think what we have learned over time, and I know I walked through two of the models that we had tested from 2017 to now, and in Medicare primary, which, just started getting off the ground before we changed priorities, we saw the same. It is really hard unless you can solve these alignment issues to get to what we see as the tipping point for practices to really lean in on behavioral change, to change the way that they are administering care. And it is a challenge that we continue to sort of think through, especially on the MA side, because obviously they are our systems that we're putting in place. Just to acknowledge, CMS sort of regulates both MA and fee-for-service. But it is difficult to move either boat just because of the given inertia and the incentives that exist. It is something that we know we need to think about. I don't know, and I will probably get the best solution is fewer, solving or having fewer pieces of the puzzle, so to speak. I think maybe it is sort of designing them smarter so that they are less confusing when viewed together. But especially as we have been using an only carrot-based model for multi-payer alignment, is something we have to think quite a bit about.
Yeah, let me add one quick point. First of all, I am a big fan of MA. I think the evidence suggests, and this may have been implied by the question, that MA on average is lower cost and comparable, if not slightly better quality. But to Karthik's point, there is widespread heterogeneity, so it's important to what one thinks there. But my enthusiasm for MA doesn't imply that we don't need to work or build for a few reasons. One is, and second, I think there's a range of reasons why people might not want to subject themselves to some of the other challenges of MA. We focus on a lot of the positives of MA. We have another meeting about some of the challenges. But in any case, we do need to have a fee-for-service system that is efficient as the fee-for-service system can possibly be, both because some people are appropriate for fee-for-service and because the fee-for-service system sets the benchmarks for the MA plans. So I think the challenge ends up being that Nicholas can only control so much once things get sent over to the private sector, like the MA plans. He can't control their legacy systems, can't control the way they do attribution, and we want that. The whole point of MA is to give them the flexibility to bring innovation and care management. But it does limit our ability to make everything completely harmonized. So to the extent possible, I think building a better fee-for-service system and harmonizing it around the types of things you would expect in MA, attribution, maybe some quality measure things, core incentives about population health type stuff. I think that's really the fee-for-service side where we can, ignoring for a moment aligning with MA, just aligning within the CMS pro payment models would be sort of step one. Then you got to figure out how you may or may not be able to align with MA. I think again, quality measures, risk adjustment might be a good place to start. And then of course there's all the other payers that aren't actually MA. I would start with Medicaid because at least the government controls Medicaid. But again, there's a federal state issue there. This is a very complicated part of the American healthcare system. And I think for starters, we need to try our best to keep it as simple as we can. It will not be simple, as simple as we can to then begin to align things to work in the right direction. But we're going to need a fee-for-service system. Or I should say a non-MA system. It may actually not be fee-for-service, and I really will be upset at myself later for that misspeaking.
Oh, thank you for that, Mike, and thank you to all the presenters who responded. Maybe as a response and comment, and maybe even a question to what's been said already. So I've had the chance to work at Dooley as a primary care provider and worked on the value-based care side. And what we had to the points that have been brought up is at least the friction that was probably the most prevalent from a primary care provider's perspective was not having as much to do with attribution or risk adjustment, et cetera. It really had to do with the quality piece of it. And this is intra Medicare Advantage, so within all the different Medicare Advantage products, and then between Medicare patients. So if a patient was ACO REACH or MSSP or Medicare Advantage. And the quality piece really came into play because the variability of that quality, of what quality meant when a patient showed up. If it's a total cost of care model or upside only model, or if the attribution is different, that did create some challenges. But it really had to do with the quality piece. And if we believe fundamentally that the outcomes we want to drive for Medicare patients are standard across Medicare products, then I think this question probably goes to Nicholas first, is how are we thinking about creating uniform set of quality metrics within a payer class so that the abrasion from a care delivery entity perspective, from a PCP seeing a patient perspective is minimized, or the variability of care delivered is minimized?
I think it's a great question, and to your point, it is. I think I spent a little bit of time talking about quality being one of the real building blocks for alignment as well for this reason. It will require us at CMS to think through internally sort of where we can not necessarily replace wholesale quality systems. I would proffer, but how we can meld sort of quality systems in new, if we're going to call it fee for service, original Medicare models with what is being done in Medicare Advantage. The Medicare Advantage quality payment system or quality bonus payments are big. There's a lot of momentum behind them. They're not going to be replaced quickly. And even altering them, as you all know, it's a comparative system. And so, changing sort of how we are measuring the star ratings measures for a CMMI model is really complicated because it creates ripples in terms of who's being compared on what measure that go far beyond the area and the population that we're testing. But those are the questions that we need to confront because, to your point, we don't want to just layer on more quality measures and more incentives and different types of outcomes on top of what already exists. So it is something that we are thinking a lot about. I think it will require us to intelligently try to balance the equity of the way that Medicare Advantage measures quality and distributes payments there, which are significant and move quite a bit of mountains, metaphorically speaking, as well as making sure that we are addressing stars ratings measures that may be pulling focus away from the things that we believe tomorrow's healthcare system really should focus on, and that is best for payments. That's not, I don't have the how-to plan here. I can tell you it is something we're thinking deeply about and hope to see quite a bit in future models. I will note, we have a little bit of experience with sort of modifying stars ratings measures in the past, and we moved away from it, and I think it's something we're thinking more about. The enhanced medication therapy management model, which was tested back in 2015, it changed the way that medication therapy management was done for participating plans. For those plans, we actually did alter the medication therapy management measure because it was prescriptive and we were giving them freedom. And I think that there's a blueprint there that we need to keep thinking about for improving the quality system in such a complicated landscape. I'll stop there and turn it back.
Mike, I think you're
if I can
speaking.
just say very quickly, I'm much more skeptical about the entire paradigm around improving quality. I think we need a much more bigger redo, but I'm going to leave that for Nicholas to sort out.
Thank you, Mike. Walter, I believe you're next.
Well, I wanted to thank our panelists for a really informative and thought-provoking presentation and discussion so far. It's just great, and I have actually several questions, but I'll start with one, and it's primarily for Karthik. So Dana had highlighted the differential performance at Dooley with MA versus traditional fee-for-service total cost of care models. And I'm just wondering, Karthik, through Agilon's single Medicare experience for its physicians and patients, if Agilon's been able to see narrowing or elimination of those disparity in outcomes between Medicare Advantage and your ACO REACH model.
Yeah, it's a good question. The short answer is we haven't. We see narrowing from a baseline of when we started with that fee-for-service full risk population, that we bring it down year over year and working with them. But we still see a delta between our fee-for-service full risk lives and our MA full risk lives. And I think Dana hit on some of the key reasons for why that's happening. I think its relationship with the PCPs tends to persist for longer periods of time. And we know that's generally one of the biggest components of driving behavior change. And so I think it's that. And I do think, as much as we all kind of point at UM and prior auths, like some of those are helpful for reducing things like skin substitute spend. And I think there's value in figuring out how we can be probably more targeted to reduce some of the abrasion and keep some of the quality improvement or unnecessary spend down in those areas.
Thanks.
Joshua?
Thanks, everybody. Appreciated those comments. I was a few of us on the committee kind of serve on the basis of a preliminary comments development team, and I had the privilege of leading that for this meeting. And I was thinking about what you shared and what our team kind of put together on a few points, and this is driving to a question I think directed at probably Karthik and Mike, but I'd welcome other, obviously any and all thoughts here. So the idea, from some of our work was that, clinicians and delivery organizations don't operationalize care around pilot programs. They're looking to do things that are more system-wide and transformative. Speaking as a primary care clinician as well, you're not trying to target, you're trying to do the best thing you can for all the patients that come through. And I appreciated, Dana, some of the comments that I think reflected that sentiment. In that way, Mike's vivid slide about many incentives and payers coming makes it hard to practice medicine. But one thing I appreciate from Karthik, you, and I think Mike, you alluded to this as well, is there's actually even more than multiple payers. I think most people think of different public and private payers, but within MA, what I've heard is there are multiple different programs, a couple dozen, Karthik, if I remember your comments correctly. Mike, you mentioned the heterogeneity. So I guess, is there anything, maybe one or two practical things you would say, how should we deal with that thing, right? Dealing across Medicare, Medicaid is something, public, private, something, but just within MA, if different plans present almost different programs, right? And there's a lot of heterogeneity, how should we think about reducing that? If Mike's point, which I agree with, having fewer programs is better, some standardization without losing innovation. What are some pragmatic ways to do that? Be curious your thoughts.
Yeah, you might want to start this one.
No, I don't have an answer. You go, Karthik.
I surely don't have an answer, but maybe a couple ideas. And so, one of the things that I think about, right, is even if you take an analogy like railroads, they all had a different gauge they were using when they started, and they switched to the same gauge to basically get interoperability across the country. And Josh, to your point, like when we think about the senior line of business, like what are those parameters of standardization that we need? Like what are just things you have to have? And I think those things you have to have to ultimately promote healthy competition for better quality care and what we're trying to achieve. I think a few areas where we can remove some of that variation or attribution, like we've hit on, I think everyone's hit on that here today, that creates a world of administrative burden that we have to go chase down. Figuring out how to create common, parameters around that would be hugely helpful. Two, I actually think about from a senior line of business, like what are we really trying to solve with our care models? And Mike hit on this from like, there's a lot of different care models out there. And it sometimes feel like we kind of flip the table upside down every few years, and which creates a lot of change that you've got to go create in a group and a change story that you then have to tell physicians on why we're doing what we're trying to do. And so I think being really clear on what we're trying to do within the senior line of business, and it could be quality goals or just a very like specific problem statement that spans different elements of that care model, I think would be really helpful for us in terms of program design and prioritizing what we're able to go and do. And ultimately, I think it comes down to, going too broad means you're not focused on anything. And we kind of battle that a lot within our own organization. So where do we really think over the next 3 to 5 years our biggest opportunities are in that line of business? I think would help create some clarity for a lot of people operating within this space. And then 3, I think this is like, one of the constant challenges too, but it's data requirements, standardization, and exchange. It's not just us. I think a lot of people spend a lot of effort in this space, dealing with different formats of data and creating interoperability within different data systems to ultimately be able to provide the care that we want to provide. So I'll throw those out as a few ideas, not answers that others can build on.
So just a few quick things. First is, in a world that's sort of MA oriented, which is based on competition, you're going to have a lack of coordination across the MA plans, which you kind of want. And so I think just going into this, you have to be humble about how you're going to solve that problem. I would start by trying to identify, I don't know what they are, maybe others would, what are the most egregious problems and how CMS might prevent those. The one area that I know there's a lot of work going on at CMS now, and maybe Nicholas can speak to, is standardizing aspects of prior auth, at least the data needed for prior auth. And I think that ends up being important. Other than that, I think as long as we have a bunch of competing MA plans, the MA plans are going to vary in whether they want the providers to engage the patients or they want to engage the patients, or they want to manage the referrals or the providers managing the referrals. One of the things, so since I don't have a better answer, I'll try and sum up with a completely tangential point. Independent of any of this, we need to support the delivery system at large. You can't have a well-running primary care system if you don't have a well-running primary care workforce. And so there's a whole bunch of things unrelated to this topic about just how we manage that. And one of the things that's going on in that space has a lot to do with integration. There's both integration of the primary care workforce with large health systems. I mentioned that briefly. There's also integration of primary care workforce with actually large carriers, including many MA plans. And in general, at least in my world, that's viewed with some disdain. and maybe appropriately, I'm not arguing against it, but there is some advantage of having an intermediate structure. If you listen to what I think Dooley does and Agilon does and other groups do, they provide some ability to take very different types of incentives coming at the system and harmonize them so when it gets down to the actual people providing care, they can manage the workforce and what happens. And there can be some standardization at a layer that's not necessarily the layer going in and that's top line layer. But what you need at that top line is you need some harmonization so that folks that are running, say, a big health system aren't trying to figure out, should I be in this MSSP track or what about reach? Wait, now it's going to be lead, but I got new teams model. But if I stay in fee for service, I can then get paid with the ASM model, and maybe it'd be better for me if I sorted that out. And then there's all these different choices that these big organizations have to make. And I think the more you can simplify those big choices, keep the core paradigm of holding the delivery system accountable for clinical and economic outcomes, you can get to a place that is broadly better and focus on getting rid of the most egregious problems. Maybe you need another meeting on what are the most egregious problems. It sounds like attribution is one in many contexts. And just say, you know what, we have a very fragmented healthcare system. That's the way the American healthcare system was built. And the fragmented healthcare system has some pros and cons. And let's just try and amplify the pros and get rid of the cons. But we're not going to solve harmonization between 5 or 6 different MA plans with different benefit designs and different people trying to run what goes on. We just have to limit the extent to which that lack of harmonization causes problems, and that may involve some pruning of types of things that those orgs can do. I wish I had a better answer.
I would agree with Michael on this one. It's we've all heard it's hard to be both simple and fair across all of this as well, which is probably another problem. But candidly, this standardization of quality metric is not the biggest thing that keeps me up at night. We can overcome a lot of that. It's clunky, it's expensive, it's harder. Karthik was absolutely right about all of those things. I also recognize I have a smaller number of payers than Karthik has to deal with, though it's not, it's probably about a third of what you do, not one. But we can overcome a lot of that if we have the right data. If we don't have the right data coming in the right formats with the right components, then there's no amount of muscle that helps us get through that to the point where it's all seamless for the provider, getting an alert at the point of care to do the thing that we need them to do. So I'd encourage looking at standardizing data requirements as a place to start. To Michael's point, I think that's more realistic than harmonizing quality measures across plans.
Yeah, on point quick, if that's okay, Henish. I think I appreciate that. And I asked the question not having any, perfect answers myself, but I think what I'm drawing from this is that, and we can bring this up more in future sessions to my other committee members, but the idea that part of the model and competition is part of what we're talking about with MA. So stamping out completely may not be realistic or even desired. I do think there's a spectrum, though, from my view, of kind of competitive ability and product flexibility turning into administrative noise. That's kind of what I'm hearing here as well. And so finding that right dial is just really important. So thank you.
Josh, thank you, everyone. Larry?
Thank you, Henish. Like everyone else, I truly enjoyed the session this morning, and I have to compliment the PCDT and staff for an excellent selection of KOLs. This was really something this morning. I always like to grab a quote from one of you, and I'm going to steal Michael Chernew's quote. It's very difficult to practice medicine when multiple groups are telling you how to practice medicine. Love that line. I think it goes to the heart of our problem today. The theme of my question here is, we heard from all of you that increasing participation is key to the success. Can we reach critical mass provider participation in a purely voluntary model system? When we look at the landscape right now, Medicare is fully at risk. Medicare Advantage, each of those plans are basically fully at risk. But on the ACO REACH side, on the looking at it from the provider's point of view, it's not as cut and dry. And I would like to ask a lead question to both Dana and Karthik. What percentage of the total revenue of your organizations is currently being derived from risk-based value-based care? You can answer it a very simple way, minority, majority, without going to a specific number, because I'm trying to make a case.
We are equal.
Oh,
2025.
that's impressive. That's impressive. Karthik?
Yeah. For us, it's actually between 95 and like 98%. So we are across all of our lives, full risk global cap.
Okay, all right. That last one was a little surprising. But looking at each of your provider groups inside your organizations, what percentage of their revenues is at risk?
So it's pretty close to what Dana said, 50-50.
Yeah, yeah. And so I'm a specialist, and looking at it from the specialist point of view, the problem always in getting more participation, maybe this falls into Michael and Nicholas's realm now, in getting participation is getting those incentives right. For the cognitive care, are you providing prepaid payments, pre-service payments to the providers to build that infrastructure? And are they really incentivized to participate, or can they just crank their fee-for-service revenue from their procedures and not really participate at the same level? How do we move this mountain, Nicholas and Michael?
I'm not going to say much about mandatory, except the obvious, that if you make things mandatory, more people will be involved. I think there's organizations I think should be forced to participate the larger you get. I think it's very hard to become mandatory when organizations are smaller. I think we can if we design the programs better, I think you'll get more participation. And I think we have to be cognizant of what we do in fee for service that will encourage or not encourage participation in these other types of models. I actually think with Medicare Advantage growing as rapidly as Medicare Advantage has grown, that we actually are doing pretty well at overall participation. I think there's an interesting question, which I, again, don't have a good answer to, about the extent to which you need, for example, hospitals, or for that matter, some specialists to be literally on the list participating versus just influenced by the primary care group. I think one of the things we've found, for example, is it's hard to keep people out of a hospital if you're a hospital. So having a world in which the risk is borne by independent primary care groups that can engage the hospitals or move people across hospitals isn't necessarily a bad thing. So again, I come to these things and I always get encouraged because hearing all the stuff that Nicholas is thinking about and what Dana and Karthik are doing, you can see the potential for success here and a lot of stuff that's going on. I think we need to try and stay the course, but that means in part simplify the course. I think part of the problem is, and what I would take away from this is, too often we get to where we are and someone sits around and says, okay, where are we? We've made a lot of progress. What new things do we need? What new things do we build? We had Reach, now we have Lead. Soon there'll be Next Gen Lead. Lead 2, there's Teams, and then there's going to be ASM. We need something for the fee-for-service specialist that doesn't want to be in the Teams model, but doesn't have something in BPCI. I just think we need to be much more humble about what we can do and try and build a very basic structure. So again, my view, we can't do this legislatively. I would get rid of MIPS. I realize that's not what we're doing. I just get rid of MIPS. I would dramatically transform the STARS program. I think it's just making things way worse. You can read the MedPAC reports. I'm not talking for MedPAC, but I think STARS is well beyond, we need to change the payment measures. I would work on attribution. I would work on some risk adjustment changes. I know CMS is doing a ton of stuff on risk adjustment. Maybe Nicholas is doing all of that. And then I would just try and let the system practice. I think all the groups like Dooley and Agilon, some others I know, Aledade, they are really helping physicians practice in a very, very difficult environment. And I think they need some stability better data, some stability about what the system's going to be like in 2030. I think if you tell them what the system's going to be like in 2030, they will find a way to make the system look the way you want in 2030, which is different than saying, oh, but we're going to, change it here. There might, even if we don't change the program you're in, we might put another one in that's better, or we might take away some, build a program to keep people out of post-acute care. But you know what? We have a new model for post-acute care, and some of those savings are now going to be given to nursing homes or whomever, right? I think you just be very cautious about how the broad infrastructure changes when you do things. So doing less, more simply for a longer time horizon, I think is important. And I worry some that our penchant to experiment is problematic because people don't really want to transform if they're just in a few-year experiment.
Thank you so much, Mike. I think we are at time. So I'd like to thank all four of our experts for joining us today. You helped us cover a lot of ground during this session, and you're welcome to stay and listen to as much of this meeting as possible, or as you can. At this time, we'll have a break until 1:10 p.m. Eastern Time. Please join us then. We have a great set of speakers for our second session, which focuses on lessons learned from state value-based care models that have implemented multi-payer alignment, Part 1. Thank you so much.
Produced by the U.S. Department of Health and Human Services.